If you're building a profitable cosmetic vein practice, sooner or later a patient is going to point at their ankle and ask you to treat the spider veins there. And it looks pretty easy, doesn't it? But let me tell you, it's not. If you're a healthcare professional and you have just started injecting leg spider veins by microsclerotherapy, you already know just how difficult and frustrating it can be to accurately inject spider veins. If you're just starting out, I strongly advise that you don't start with ankle veins, no matter how tempted you are. Why is this? What's so special about this area of the leg? Well, before you even reach for your syringe and needle to start microsclerotherapy injections, you must stop and ask yourself one question. Are these simply cosmetic spider veins, or is there something else going on here? In this video, I'm going to show you why a cluster of spider veins at the ankle isn't always what it seems, and why it's one of the last places a beginner should start injecting, and what the evidence and the guidelines actually say and tell us what to do instead. And be sure to stay to the end, where I will tell you my top tip for when you do eventually start injecting spider veins around the ankle. And in that way, you can keep your patients safe and avoid serious complications. Why is the ankle so different? Well, most spider veins on the leg fall into a category called CEAP C1, fine intradermal telangiectasia, often fed by a blue reticular vein. And in the absence of symptoms, these cosmetic spider veins can be safely and effectively treated by microsclerotherapy injections. That's true for spider veins on the thigh, it's true for spider veins on the calf, but on the ankle, well, that's a different story altogether. Around the ankle, either the medial or lateral malleolus, it's very likely you will see a fan-shaped pattern of fine vessels with skin changes, and this pattern is called Corona Phlebectatica. Since 2020, it's had its own place in the CEAP classification, not C1, C4c. This reclassification is really significant because C1 and C4c are not managed in the same way. C1 disease can be treated safely and effectively by microsclerotherapy without investigations. C4c disease requires investigation by Duplex ultrasound before microsclerotherapy. Why? Because Corona Phlebectatica is associated with superficial venous disease and incompetent perforator disease, or sometimes even both. The evidence comes from a study by Earl and colleagues who looked at clinical and duplex records of 287 patients across 10 European countries. They found that the more severe the Corona Phlebectatica, as judged clinically, the more likely the patient was to have superficial venous reflux, and in particular, an incompetent perforator veins. In fact, patients with Corona Phlebectatica had a 4.4-fold higher relative risk of having an incompetent perforator on Duplex compared with patients who didn't have Corona Phlebectatica. A follow-up study by the same group in 262 patients looked at which features of the Corona Phlebectatica pattern were most significant. Blue telangiectasias and stasis spots turned out to be the most significant markers of underlying venous disease. So, what should we do clinically? Well, an ankle flare warrants investigation by duplex ultrasound before microsclerotherapy. And there are two main reasons why the ankle region is a really bad place for beginners to start performing microsclerotherapy. The first reason is diagnostic. Even very experienced clinicians cannot determine reliably, just by clinical examination alone, whether spider veins at the ankle are associated with more significant superficial venous disease. So, experts agree that spider veins at the ankle require prior investigation by duplex ultrasound to correctly categorize them as either C1, or C4c. The second reason why the ankle region is not a good place to start performing microsclerotherapy injections is anatomical. Around the ankle, neurovascular bundles are very superficial. They're close to the skin, and this puts nerves and arteries at particular risk of inadvertent and accidental injection of sclerosant. A 2024 international consensus guideline on inadvertent intra-arterial injection of sclerosants, which was also endorsed by the International Union of Phlebology and several other vascular and phlebology societies, formally names the ankle region amongst the highest risk sites for this specific complication. The medial ankle carries the posterior tibial artery close to the veins you'll be injecting. The anterior ankle carries the anterior tibial artery and the dorsalis pedis artery. Both sit right below the fascia alongside their accompanying veins. Intra-arterial injection of these arteries is rare. The guidelines' own authors say that the true incidence is unknown and it's probably underreported, but when it happens, it's catastrophic. The guideline documents an early case series where 4 accidental injections into the posterior tibial artery all caused distal necrosis, 1 requiring amputation. It also documents a case where a practitioner injected both ankles in the same session and caused bilateral below-knee amputation. So if you're inexperienced, stay away from the ankle and don't attempt injecting spider veins around the ankle until you're very skilled. At the end of this video, I'll give you my top tip for avoiding any serious complications and the catastrophe of intra-arterial injection once you do start injecting around the ankle. So let me give you something practical to take back to your clinic. You should get a duplex first when the pattern of spider veins is around the malleolus, fan-shaped, if there are symptoms, edema or skin changes, or when you need to confirm whether you're looking at C1 or C4c disease. You don't need to duplex every straightforward cosmetic spider vein on the leg, but at the ankle, never assume that spider veins are straightforward and just cosmetic. It's always worth getting a duplex scan for spider veins at the ankle to carefully assess them before undertaking microsclerotherapy. You can treat them locally once the duplex scan has excluded significant incompetence or once any proximal reflux has already been addressed, and once the patient understands that ankle spider veins have significant risks. If a duplex scan shows proximal superficial venous reflux or an incompetent perforator, microsclerotherapy just won't work. It won't deal with the spider veins, and it might just expose your patient to unnecessary risk. So let me sum up. Ankle spider veins are not automatically C1 disease. A fan-shaped pattern may be Corona Phlebectatica, now classified as C4c. The clinical severity of Corona Phlebectatica correlates strongly with perforator incompetence, with a 4.4-fold relative risk in the best available study. ESVS 2022 supports getting a diagnostic duplex first, treating proximal and perforator reflux first, and then selective microsclerotherapy after that. There's no dedicated evidence for microsclerotherapy at the ankle, so decisions here rest on classification and sequencing, not on direct outcome data. And for anyone early in their learning curve, this is an area worth avoiding until you've built up experience on other parts of the leg first. Now, at the beginning of this video, I told you I was going to give you my top tip for accurate spider vein injections, particularly relevant around the ankle. Well, as a beginner, the tendency is to inject too deeply, and that's why injecting around the ankle can be so dangerous. The injections can even be so deep that they go through the spider veins and completely miss them, hitting the arteries and nerves underneath. Therefore, I advise that as a beginner, you start off by bending the needle 10 to 15 degrees. Place the needle flat on the skin with the bevel up and slide the needle forward. This tip will ensure that your injections remain very superficial within the skin, and as a beginner, you will avoid the danger of injecting too deeply. By bending the needle, you'll increase your accuracy, and I've covered the injection technique in other videos. I'll put a link in the description below to videos that you can look at if you want to see the bending of the needle and sliding the needle forward into the spider veins. And if you found this useful, the full written review with the complete evidence base, the table of references, it's linked in the description box below. And if you're building a cosmetic vein practice and want structured, hands-on training in microsclerotherapy, radiofrequency thermocoagulation, or the combination of the two, that's exactly what we cover in our VeinCare Academy courses. The details are in the description. My name's Dr. Haroun Gajraj. Thank you for watching.